I am presenting a case of Miss S, a 22-year-old lady who is a resident of Jasol, hasn't received any formal education, and is unemployed, who presented to the medicine OPD on 15th July 2021 with the chief complaints of swelling in the legs for the past 7 months, cough for the past 6 months, and breathlessness for the past 6 months. 7 months back in January, following a month of amenorrhea, she confirmed her pregnancy with a positive urinary pregnancy test, and she was unable to recall her LMP. The patient was apparently well 7 months back when she started developing swelling in both her legs, which was insidious in onset. Initially, it used to be up till the ankle and got relieved following 1 to 2 days of rest. But now it has progressed to reach up till the knee and does not resolve on rest. For the past 6 months, she has been having cough, which is insidious in onset, gradually progressive, and sometimes associated with scanty pink frothy sputum and tinged with droplets of blood. The cough increases on lying down, and there is no diurnal or seasonal variation associated with the cough. The patient also complains of breathlessness on exertion for the past 6 months, which is insidious in onset. The patient became breathless initially on climbing 1 flight of stairs and now has gradually progressed such that she becomes breathless on walking about 100 steps on level ground. The shortness of breath has started to increase on lying down recently, orthopnea basically, which requires her to keep 2 pillows beneath her head while lying down. There's also a history of acute episodes of breathlessness occurring after few hours of sleep at night for the past 3 months, which make her wake up and gasp for air and get resolved with deep breathing for 15 to 20 minutes. These episodes occur 1 to 2 times per week. On 11th July, 3 weeks back, she had a miscarriage at home, following which she visited a primary healthcare center and got referred to Loknayak Hospital after a series of investigations. There were no complaints of chest pain, palpitations, bluish discoloration of face or lips. There's no history of yellowish discoloration of the eyes, upper abdominal discomfort, abdominal distension, fatigue, or syncopal attacks. There's no hoarseness of voice or dysphagia. There's no complaints of face or arm weakness, speech slurring, or sudden vision changes or decreased urine output. There's no fever, weight loss, rash, photosensitivity, or joint pains. No flushing or diarrhea. Past history. The patient gives history of episodes of shortness of breath, diaphoresis on exertional activities like dancing throughout her teenage years, but there's no history of any childhood fever associated with joint pains or rash or abnormal movements or hematuria. She hasn't had any dental extraction, and there's no known history of diabetes, hypertension, tuberculosis, or previous hospitalization or any long-term illness. The family history, there are no similar complaints in the family. Menstrual history, she achieved her menarche at 12 years of age. Cycles were regular with normal blood loss each month. She cannot recall her last menstrual period. Obstetric history, the patient is para 2, live 1, and abortion 1. Her first child, 2.5 kilogram male, was born in November 2018 with a full-term normal vaginal delivery conducted at Lady Harding. He cried at birth, was exclusively breastfed for 25 days, and has achieved all milestones for his age. There were no pre-intra postpartum complications in the mother. There has been no use of contraception since then. Her last pregnancy was a spontaneous conception confirmed by a urinary pregnancy test at 4 weeks of amenorrhea. She had 5 ANC visits at a primary healthcare center wherein she was informed about a low-lying placenta and advised bed rest. After the miscarriage, she went to the primary healthcare center from where she was referred to Loknayak Hospital after a series of investigations. Personal history, she takes a vegetarian diet with adequate protein and calorie intake. The patient reports disturbed sleep, because of the aforementioned attacks of breathlessness at night. There's no history of smoking or consumption of alcohol or tobacco or any high-risk behavior. Bowel and bladder habits were normal, and there were no known allergies. She belongs to the upper-lower socioeconomic class by the modified Kupuswamy scale, and the drug history wasn't significant. So summary, Miss S, a 22-year-old lady, presented to us post-spontaneous abortion with bilateral lower limb edema for 7 months, cough with pink frothy expectoration and progressive dyspnea associated with PND and orthopnea for 6 months. She progressed from NYHA class 1 symptoms to NYHA class 4 over 6 months. There is no significant history suggestive of past rheumatic fever, infective endocarditis, but there's history of exertional dyspnea and diaphoresis throughout her teenage years. So differential diagnoses are valvular heart disease, either mitral stenosis or mitral regurgitation, and dilated cardiomyopathy. So should I carry on?
Okay, so go back to your presenting complaints.
Yes, sir.
Okay, so the presenting complaints, we had swelling in the legs past 7 months, cough for 6 months, and shortness of breath for 6 months.
Yes,
Okay.
sir.
Okay, the next slide then. So before we describe this, before we go into the HOPI, we are sort of clear that we are dealing with a case of cardiovascular system.
Yes,
because we are having likely pedal edema, we are having shortness of breath. The cough
yes,
is there, which is a sort of a confuser, which can be there in patients with respiratory symptoms as well. However, we'll get to see, you have described it in the history of presenting illness, that it was likely a cough secondary to heart failure.
Yes.
So, okay, so then you said, okay, we can, in this history, when you're describing the swelling in the both her legs, insidious onset to go up till the ankle, but now to reach up till the hip does not resolve on rest. Okay, so you have described it, but 1 or 2 points that you can add is that, or you can ask from the patients is that, does it leave the imprint of the footwear that they're wearing? Sometimes they're wearing those slippers or the sandals that they're wearing because of the edema. It is there. Now, one thing that we need to know about in this history, which is missing, is that 7 months back she had the swelling, which she noticed in both her legs. Now, at that time it was there till the ankle. So during those 7 months, has she, consulted anyone? Has she taken any medicine? You could say in such a way. Sorry.
Yeah, so I asked her, so she said she thought that it was because of the pregnancy only, so she did not seek any like medication for it.
So what you have to mention here is that, okay, so at that time she was also having this, but see, देखो pregnancy भी अगर है तो at that time when she was having a positive UVT, तभी उसी time पे उसको pedal edema था, immediately तो नहीं होता है. Anyhow, more importantly, what I want to focus is that you should look for you should have mentioned that for this, either she had not consulted anyone, you could have mentioned, or she has not taken any medicine, or the thing that we want is that, has she taken diuretics for this? Okay, which has increased her urine output. So that could have been mentioned here. That the patient, let's suppose if she would have taken, consulted someone and was given a medication for which the swelling got relieved, but it occurred again even once the medicines were stopped.
Yes, sir. Okay.
So this will tilt your pedal edema more towards a cardiac cause.
Cardiac cause.
ठीक है. अब देखो, plus one more thing, when you are describing the swelling in the legs, you did not tell that the patient is having associated facial swelling, abdominal distension. Abdominal distension आपने बाद में लिखा है, but ideally you should have written that this swelling was limited only to her legs, because swelling in the legs can be because of the four systems that we all know of.
Yes, sir. Yes, sir.
It could be cardiovascular, could be liver, could be kidneys, or could be the nutritional. So
Yes, sir.
basically ये चीज आपको, that is why
Hmm.
the history of any medicine which increase the urine output and decrease the swelling will go
Yes,
more
sir.
towards in the favor of a cardiovascular. It could be in a case of renal as well. However,
Hmm.
cardiovascular symptoms getting relieved with uh, this
Diuretic.
medicine would tell
Yes, sir.
that it is going towards the cardiovascular system. Swelling is
All
because
right.
of that. ठीक है?
All right.
And the one more history is telling that he or she noticed that the imprint of the footwear was there. ठीक है?
So will that tell us about like the severity of edema?
It is not about severity. It is usually what the patients say, because for them
Okay.
that is how sometimes they notice that जो चप्पल पहनी थी या जो
Mm-hmm.
वो पहने थे, that they saw that on their feet, and like that. That is why they
All right.
contacted the. So the next slide.
Yes, sir.
Okay, so she's having cough. So this was fine, droplets. There's no. One thing you could have skipped here is that there is no seasonal variation, because within 6 months it is not right to comment on seasonal variation.
Okay. We can say it only
अच्छा,
like when the duration
yeah,
1
only
year.
diurnal variation. Yeah, only diurnal
Okay.
variation.
Okay, sir.
ठीक है. So had the history been for 1 or 2 years or more than that, you
Then,
could have said seasonal variation.
all right.
Uh, the next point is something which I want to point out, because this you have. I think the description is slightly off, especially when you have said it in your summary as well. Now you're saying that the patient had shortness of breath, insidious in onset. The
Hmm.
patient became breathless initially on climbing one flight of stairs. Now, climbing one flight of stairs is something which is not an insidious onset of shortness of breath,
Okay.
because one flight of stairs is something which is less than normal activity.
Yes, sir.
To make myself more clear, I would say that in your summary, you had said that the patient went from NYHA 1 to NYHA 4
1.
in 6 months.
Yes,
Now,
sir.
how is he NYHA 1 when initially he was breathless on one flight of
But
stairs?
so he'll be NYHA class 2.
Yeah, at least 2 or even 3 as well. Because see, when you are saying, whenever you are describing breathlessness on exertion, I
Hmm.
repeatedly tell all the students that always try to describe the normal activity of that patient or the person whom you are taking the history of. Okay?
Okay.
Even
Hmm.
if you are not describing the normal activity of that patient,
Hmm.
you should
Hmm.
never settle when they. Let's see what happens is you are taking the history of the patient 6 months down the line, and
Yes, sir.
obviously the patient will just try to say you in a vague form that
Hmm.
अभी तो मेरी सांस बहुत फूलती है, अभी मैं चल भी नहीं पाती, लेट भी नहीं पाती, हाँ 6 महीने
Yes.
से हो रहा है. And
Hmm.
obviously she or he will not have the recollection what happened 6 months back.
Exactly. Yes,
however
sir.
however you have to uh, force things, or maybe be more particular about that. When was she absolutely normal?
Right. Okay. Yes, sir.
Because in such cases what happens is this duration changes. What happens is patients usually say कि हमारी 4 महीने से 5 महीने से सांस फूल रही है. अब तो ये
Hmm.
हालत हो गई है कि अब हम चलने में, अब वॉशरूम तक जाते हैं तो सांस फूल जाती है. अब
Hmm.
तो ये हालत हो गई है कि हम लेटते हैं तो भी सांस फूलती है.
Yes,
दिस
sir.
इज व्हाट. सो देन योर नेक्स्ट स्टेप इज यू आस्क, अच्छा 5 महीने से दिक्कत हो रही है, 5 महीने पहले क्या
Hmm.
हुआ था?
Hmm.
तो तब थोड़ा फूलती थी, बट अब बहुत ज्यादा फूलने लगी है. दे विल ऑब्वियसली नॉट फोकस व्हाट हैपेंड 5 months
Hmm.
back.
Exactly. Yes,
However,
sir.
if you ask them that
Hmm.
what were you able to do 5 months back,
Hmm.
and
Hmm.
what were
Hmm.
you able to do 2 years back? So that is why this description that I was trying to elicit,
Yes, sir.
this is a thing which is a good point. I am not saying that it is a mandatory point to be mentioned in your history, but if you
Hmm.
mention whenever, whether it is a respiratory case or it is a cardiovascular case,
Yeah.
if you mention what the patient's routine activity was.
Hmm.
Uh, how does that make a difference? The difference would come, let's suppose you are presenting a case who is a daily wage laborer, and let's suppose
Yeah.
you are presenting a case of this young lady. Now, this
Hmm.
young lady I did not hear about that, what was her education level, but let's suppose she is a college going student, or let's suppose she is working after passing her
Yes.
12th onwards, she's working. So the activity levels of this person would be different from when you compare to a person who is a daily wage laborer. And it would be
Yes.
different from a person who is driving a auto rickshaw, or it would be different from a person who is working in a 9 to 5
Yes.
office job.
Yes.
So let's suppose a person who is working in an office job works on second floor, and he usually climbs 2 flights of stairs.
Hmm.
And climbing 2 to 3 flight of stairs is considered normal for a young,
Normal.
healthy male. You can easily climb 3 flights of stairs. After that, you may have some shortness of breath, but till 3 flights, it should not be an issue for a healthy young male or female.
Yes.
However, let's suppose a person who is going to his office and is having routinely climbs 2 flights of stairs. He will also, and he presents to you and he will say the same. Yeah, let's suppose we
Hmm.
take this patient only who resides on third floor and has to climb 3 flights of stairs, but is now noticing that she has to stop in between. Then
Hmm.
this is the way that you can elicit from the patient that when was the last time, एक
There
साल,
was
दो
time.
साल, 3 साल पहले,
Yes.
where when you were able to do these things normally. NYHA
Yes.
1 is something you are not having any shortness of breath in even
Yes.
some more than ordinary activities. 2
Hmm.
is at ordinary activities, 3 is at
Obviously.
less than ordinary.
Yes.
So
Right.
even
Yes.
if you
Sir.
take, you have to define ordinary for the person.
Hmm.
गलती कर
I
लो
hope
चल
you're
दो
getting the point.
मिनट
Sorry.
So I think that was Piyush.
Okay. Okay.
Yes.
So what I hope you're getting the point that you have to
Yes. Yes. Sir.
define ordinary.
Routine for the person. Yes, sir.
Yeah. And now one more thing at this point only. You have mentioned, I think, in your past history that she had episodes of shortness of breath during her
Yes.
teenage years as well.
Yes. Sir. Yes. Sir.
So now what happens is that this changes most probably if you would have asked her properly or would have asked her in detail, it could
Hmm.
have been possible that your history would have changed from 6 months to 4 years.
Hmm. All right. Yes, sir.
The reason being that, see, right now, I would not say that this is the wrong way of presenting the history. This will also go. But
Hmm.
if you talk about the ideal sense, or if you want to talk about the going into the real detail of the patient, so in that sense, one thing that is slightly off in this history is patient presenting to you with pedal edema. Okay,
Hmm. Yes,
now
sir.
pedal edema is there, shortness of breath is there. In
Hmm.
these presenting complaints and with these HOPI, you cannot keep the diagnosis as valvular heart disease.
Yes. So like it becomes heart failure.
It could be heart failure, but if it is heart failure in a 20-year-old female, that is also
Okay.
something that will raise eyebrows. What is
Okay.
causing heart failure in a young female? Why
Hmm.
can't
Yes.
it just be anemia?
Okay. Yes, sir.
Okay, why can't
Yes.
it just be anemia? A patient who is having a nutritional deficiency is most
Mm-hmm.
likely having nutritional deficiency in terms of protein intake and in terms of these vegetables and fruits, and that is why or plus is she is having she has already had one pregnancy.
Mm-hmm.
The menstrual cycles may have been normal, but she may be losing more blood from there.
Blood.
Why can't this patient be anemic?
So actually, at examination, like she had pallor and she was anemic.
So she had pallor. So how can you attribute that this is a case of We'll go to the examination later. We were just talking about the history aspect.
Yes.
The thing with that is what I was saying, that see, if you take this history 4 years, you say
Mm-hmm.
that patient was having shortness of breath for let's say 6 years. She's 22 and teenage. I would say let's suppose 14 or 15 years of age. She was having her
Yes.
first symptoms. ठीक है. So if you keep the onset of history or onset of symptoms at 16 years of age, now for past 6 years she was having episodes of shortness of breath. She was trying to cope up with it. That shortness of breath gradually progressed. One thing that will come during the obstetric history is that was that obstetric history, the history of pregnancy, the first pregnancy was that absolutely eventless. So
Yeah.
that we'll discuss at that time also.
Okay.
Then over the course of these 6 years, some valvular heart disease is there, which has gradually now led to right-sided heart failure, which has led to she presenting to with pedal edema.
Yes, sir.
Are you getting this point?
Yes, sir. Yes, sir.
So this is something which is slightly off in this history. And
Yes, sir.
then coming back to the point out which I made, that it cannot be possible that the patient became breathless by climbing one flight of stairs and now has become breath. Uh, the other thing which is, you know, sort of, uh, I would say slightly wrong is that patient was breathless in climbing one flight of stairs 6 months back and has gradually progressed that she's breathless on walking 100 steps on level ground. Now, if you compare the level of activity, these two are almost similar. So in a way, you are saying that the patient has not progressed for last 6 months.
6 months.
If you
Yes.
compare walking on a level ground 100 steps or and then you're comparing one flight of stairs, it is almost comparable. Okay.
Okay. Yes, sir.
So this patients will obviously, you guys will be facing this problem very commonly. Patient has presented to you whenever you're taking a case. A patient who has been just been admitted 4 days, 5 days back will only talk about last 5 days or last 7 days because that is the time where he has been most troublesome. However, if you try to ask him or her in a different way possible, that when were you absolutely, yeah, what, let's suppose you're talking about a patient who is a 40-year-old male, okay, and he is again hell bent on just saying कि मेरे को last 2 हफ्ते से बहुत सांस फूल रहा है. Then you
Yes.
start asking him what was your occupation. Now he tells you that his occupation is a shopkeeper. If he's a shopkeeper, how does he go travels from his home to his shop? Okay,
Yes,
so
sir.
that ways he will tell you, I go by my car, I'll go by my metro, I'll go by some public transport, whatever it is.
Yes,
So
sir.
then you ask, uh, do you have any difficulty while going to your shop? If he says no, I don't have any difficulty, then you ask what else, where else you travel by foot, or on which floor do you reside? Do you use stairs to climb those floors? So this is
Yes.
how you elicit where when he was normal, what was the activity and what has happened now. Okay.
Okay. Yes, sir.
So the next point is fine. You have described fine that orthopnea has happened now. Okay. Next slide. Anyone who is having any doubt can put up a question on that this questions and answer form that is there. Okay. So this thing that you have described, this history of acute episodes of breath occurring after, wait a second, this is after few hours of sleep. Okay, for past 3 months we wake up. Okay, did she mention anything about like she gets relieved after hanging her feet down by the side of the bed?
So she just said कि बैठ के जोर जोर से सांस लेती थी तो ठीक हो जाता था. Now like I think I
बैठ
should have
के,
asked कि आप कैसे बैठते थे. हाँ, like टांगे लटका के
yes.
बैठते थे.
So
Yes, sir.
yes. So this is important in a case of PND. Okay, so
Yes.
that you have to mention as the breath got resolved after she sat by her side by with the legs hanging by the side of her bed.
Yes, sir.
And this is very good that you have mentioned that these episodes occur. You have mentioned the frequency of these PND. That is a very important thing which is commonly missed.
Yes,
Okay,
sir.
so 1 to 2 times per week, it's good. And you could, मतलब ठीक है, अभी हो सकता है इस केस में नहीं होगा, but in some cases it you could even mentioned that initially the frequency was once a week. However, for last 1 month, it has increased to even 2 or 3 times a week. Okay.
Yes, sir.
Okay, then I think this is fine. Miscarriage at home. Okay. Now, no complaints of chest pain, palpitations, bluish discoloration of face or lips. Now, what are you trying to tell the examiner by this negative history?
So like we take the negative history of other cardinal symptoms of the cardiovascular system. So
Of the
like so
symptoms.
chest pain.
So you are saying that the
Yes, sir.
patient does not have a history of palpitation and the
Yes,
patient
sir.
is not having chest pain. Uh, why do you mention cyanosis?
So like I thought about this, and like the only reason I mentioned it, like so it's one of like the cardinal symptoms of cardiovascular examination.
Could
The
this
otherwise
patient
like
be,
mitral stenosis has like matlab complicates into like cyanosis occurs late in
don't
mitral
think that this is a
stenosis.
case of mitral stenosis.
Yes, sir.
See, don't think of it that this is a case of mitral stenosis.
Yes,
This is a cardiovascular system that you are dealing with. Now, in this
yeah,
cardiovascular system, the patient is having shortness of breath, is having pedal edema. So it is
yeah,
justified that it is chest pain and palpitations. Why
yeah.
cyanosis? Any other differential that could be? Anyone else? You can put up in the questions or I think in the chat if you
Sir, there are like two questions in the
want. Okay,
questions.
wait a second. I did not see that. I had.
Yes, sir.
Okay, so valvular heart disease, the symptom should be present for years. Yeah, that is what I have been trying to explain for last 10 minutes or so. That if you're keeping a differential of valvular heart disease in 6 months, it is slightly offbeat. Okay, because uh, in 6 months, it is difficult to keep a differential of valvular heart disease. That is what I've been trying to explain. So, and the next question is, if orthopnea is there, why do we need a detailed P&D history? You need a history just to augment your diagnosis that the patient is. It is not always necessary that the patient will be having orthopnea. Uh, Someone who is having orthopnea will be having PND as well. Someone who is having orthopnea and PND just adds on to the diagnosis, nothing else. But obviously, whenever you're describing a person who is having PND, you need to describe it in detail. So coming on to this cyanosis that I'm asking, why do you
There
think
could
that
be,
this is
so
a
there
history of
could be
cyanosis?
so some worsening of congenital cyanotic heart disease. Maybe.
Yes, VSDs do not present with cyanosis. Okay, now the next history, there is no history of yellowish discoloration of eyes, upper abdomen discomfort, abdominal distension, fatigue, and syncopal attacks. What are you trying to rule out from this?
So like symptoms of right heart failure and left heart failure. So right heart failure will cause the back pressure and cause congestive symptoms in the liver, which can cause the liver to swell up, and like the stretching of the capsule can produce upper abdominal discomfort. And similarly, the congestion can also like affect the hepatocellular function and cause jaundice. And so left heart failure can lead to a fatigue and like reduced cardiac output states, so like can occur like syncope or
Okay, good.
pre-syncopal attacks.
Okay, so we come on to the next slide. Okay, now in this you're saying hoarseness of voice and dysphagia, that is fine. Then weakness of face or arm, slurring of speech. Decreased urine output can come as a separate point because that is affecting the kidneys. That is not related to this.
Okay.
Then what about this rash, photosensitivity, and joint pains? Why are you asking this?
So sometimes autoimmune diseases can also be a cause for valvular heart diseases. And so
Which
fever,
auto?
weight loss, and rash for like infective endocarditis.
No,
or cardiac?
infective endocarditis is fever, joint pains, rash over the body.
Yes, sir.
Okay, so that is what infective endocarditis is. But how do you explain autoimmune disease causing cardiac illness or valvular heart disease?
So like I read it in a table in Harrison's, like SLE causing mitral, like one of the cause for mitral stenosis.
SLE can cause mitral valve collapse, but mitral stenosis या MR तो बहुत unlikely है.
Okay, okay, sir.
Or lupus, maybe some the endocarditis is there. That could be because of SLE. चलो ठीक है.
Okay.
Flushing और diarrhea क्यों पूछा?
So that's also like a really rare cause, and I was really debating with myself whether to put it or not. So like carcinoid
No,
syndrome,
you
like
should not.
okay, sir.
Unnecessary. Do not commit yourself to things which are very, very rare,
Yes, yes,
because
sir.
that will land you into further soup. Dysphagia,
Yes.
she's asking because she's suspecting left atrial enlargement, which will impinge upon the esophagus and cause difficulty in solving. Okay, so next slide. Okay, wait a second. I have to minimize this question. She was shortness of breath, diaphoresis throughout her teenage years. So now this history becomes important. The
Yeah,
history of
yes.
childhood fever, joint pains is okay.
Mm.
You need not mention history of dental extraction. Not needed.
Okay, okay.
Then last is fine. Next slide. So no complaints. Menstrual cycles. Okay. Okay, fine. Next slide. Now, in this obstetric history that I was trying to point out was that this, when you're describing the first child, 2.5 male, okay, that is fine, normal delivery. You should have described a bit more about mm, the during the antenatal period. Basically, during
Okay.
the pregnancy, does she have any complaints to suggest of any shortness of breath, any palpitations during this time, anything like that? Did she develop pedal edema during that time? If she was
Mm,
attributing pedal edema during this pregnancy to pregnancy, did she develop pedal edema during the last pregnancy?
yes. I didn't specifically, I did not ask for pedal edema specifically, but like I asked many times कि
Okay.
पिछली pregnancy में कुछ भी हुआ था तो मतलब she मतलब repeatedly said no, but like I should have asked for specific symptoms, I think.
Yeah, you need to ask for these specific symptoms, because when she's saying that she used to have shortness of breath while dancing or something like that,
Yeah, yes,
so
sir, yes, sir.
she definitely would have some symptoms during her pregnancy,
Mhm. Yes,
because
sir.
it is a case during that time the volume is increased. It
Yes.
She may not be having any symptoms during the initial phase, but in the third trimester she may be having symptoms. Okay.
Okay, sir.
Okay, the next point is fine. Next slide. Not yet. Okay, this is fine. This is fine. Vegetarian. Okay, you should not commit that she takes a vegetarian diet with adequate protein and calorie intake, because I'm sure you guys will not want your Viva to be going into the PSM Vivas and what adequate protein that she has taken, how much is the
Yes.
adequate protein for her and all that. So do not just say that she is vegetarian by diet or a non-vegetarian by diet. That's it. Okay.
All right. All right.
Do not
Yes,
say
sir.
adequate protein and calorie intake. Next slide. Okay, upper lower. Okay, not significant.
The next slide.
Okay, next slide. Next slide. Okay, so you have summarized it fine, presented to us this. Okay, this is good. Okay, this NYHA class 1 to 4, you have
Yes.
to either change in your HOPI or here.
All
Okay.
right. Yes. Yes, sir.
There's no, okay. Okay, but then do not mention this, that there is no significant history suggestive of past traumatic fever and endocarditis. That is fine, but don't
Okay.
mention exertional dyspnea and diaphoresis, because now you yourself are, you know, telling the examiner that you are confused, that she is
Mhm.
having these symptoms for during her teenage years as well. That is not adding
Yes.
to your diagnosis. Either you should have included this in your presenting complaint, or
Okay.
you should not then tell it in your summary. Okay, next,
Okay.
coming on to the differentials. Now, when you say differential diagnosis, you have to tell differential diagnosis. Mitral, first of all, see in the history that if you're talking about the presenting complaints that you have put forward, I would say that she's having anemia as the first differential.
Yes,
Okay,
sir.
you
Yes,
cannot
sir.
make a differential
Mm.
of valvular heart disease with
6 months.
months of history. Now,
Yes,
let's
sir.
suppose if you're keeping a differential of valvular heart disease, in valvular
Mm.
heart disease, you should say that valvular heart disease, likely the valve involvement. Okay, now
Okay.
why are you thinking that this is mitral stenosis? Why are you thinking that this is mitral regurgitation? Why can't it be aortic valve involvement?
So, so like orthopnea, dyspnea are like very prominent symptoms in the patient's history. So like basically we see the left heart is failing. So that's why
Yes,
it's a mitral valve and an aortic valve. Like if suppose it's aortic stenosis, then we would have gotten features of either syncope or like yeah. So dyspnea was there, but like syncope, histoionicity, and aortic regurgitation. Means
chest pain
there's
nahi tha.
a lot
Chest
of
pain nahi tha.
left chest pain, and so palpitations are also not there, like so because of the dilated heart, like some palpitations
Yes, so
would
that
have.
is the now keeping this point only, keeping your point forward only. You're saying that there is history of orthopnea and PND, so you will keep obviously mitral valve first. Uh, that is fine, understandable. But how do you say that the patient is having mitral regurgitation when the patient is not having any history of palpitations? What is the first symptom of mitral regurgitation?
So
Okay, just
palpitations
I'll keep this question open for the entire class. I would want you guys to put in your input through this questions wala box. Mitral stenosis. What is the classical presentation of mitral stenosis? I'm talking about the symptoms. I'm waiting for your answers in this questions box.
um,
Dyspnea on exertion, palpitations. No, I would not say palpitations.
so for
Dyspnea,
mitral
yeah, for mitral stenosis, dyspnea on exertion is there. Apart from dyspnea on exertion, what is the next symptom?
hemoptysis and orthopnea PND, like due to the pulmonary venous congestion.
Something that you should be clear. No fatigue is not there. Remember one thing, in mitral stenosis, your left ventricle is not affected.
Yes.
Is it clear? Because in this, whenever you are talking about any valve, any disease, you will always think in a way that because of now you know that mitral valve is stenosed. Because of the stenosis of mitral valve, whatever is happening before the mitral valve. So the left ventricle is not affected. In a case of mitral stenosis, the ejection fraction for left ventricle will remain 60% for years and years to go, and the patient will not have any history suggestive of fatigue or syncope. Now the progression would be in mitral stenosis, left atria will dilate. So dyspnea on exertion, yes, Nilayan has written PND, orthopnea in that order. Thereafter, palpitations, fatigue, right? No. Dyspnea on exertion is fine, PND is fine, and orthopnea in that order, that is good. After that, what will happen is because of the dilation of the left atrium, the patient may land into atrial fibrillation because of the stretching of the atrial fibers. They may start having ectopic foci and will land into atrial fibrillation. So the patients will be having arrhythmogenic palpitations and साथ में features of right heart failure. Yes, the features of right heart failure will start happening when uh,
The
once your pulmonary artery pressure is increased to a lot of extent.
yes.
You will go into right ventricular hypertrophy, then you will go into right heart failure. Okay.
Yes, sir.
Now we talk about mitral regurgitation. Mitral regurgitation, what is the symptomatology, the order of symptomatology?
So, first of all, there's left atrial and left ventricular dilation. So, there's palpitations, and
Exactly.
then
So in mitral regurgitation, the presenting complaint would be palpitations, or even if it is not the first complaint, it would come very soon after patient is having dyspnea. Okay.
yes, sir.
So without palpitations, thinking of a, see, whenever palpitations are two types, we know it is either volumogenic or arrhythmogenic. Okay. So we are
Hmm.
talking about chronic only palpitations. We are not talking about acute lesions right now. So
Hmm.
chronic MR is having palpitations with RVF and pulmonary hypertension. That is good. So that is what I'm saying, that uh, regurgitant lesions, whether it is AR or whether it is MR,
Hmm.
will always have palpitations because the
Yes,
heart
sir.
is made to work more.
Yes,
MS
sir.
can have palpitations, but those palpitations will not be the first or the second symptom. The palpitations will come when the left atrium has
Atrial.
enlarged to an extent
Yes,
that it is now going into arrhythmogenic palpitations.
yes, sir.
And for AS, we all know the common mnemonic of ASD, angina,
ASD,
syncope, and dyspnea.
dyspnea. Yes,
Symptoms
sir.
can come first. It is not necessary that angina will come first. Okay?
Hmm. Yes, sir.
So you guys, whenever you are saying a diagnosis, you would say valvular heart disease, likely acquired, then the
Hmm.
likely valve involvement that you're suspecting, then you would comment whether it is a stenotic lesion or a regurgitant lesion.
Okay.
Then you will, after that, you will say that the patient is currently in, seems to be in,
Normal
because
sinus
अभी आपकी
rhythm.
कोई, हाँ, seems to be in sinus rhythm, because this is what I'm talking on history.
Hmm.
Because अभी
Yes.
आपको उसने palpitations की कोई complaint नहीं दी है,
Okay.
तो is seems to be in sinus rhythm. ठीक है?
Yes,
Then
sir.
after the sinus rhythm, you would say
With features of
with
pulmonary hypertension.
no history of with no features suggestive of infective endocarditis or acute traumatic fever. That is how you say your complete diagnosis in cardiac cases.
So I've written this like after examinations in my diagnosis. Do we need to write it in like after history also in the summary?
Yes, just pause for a second. I'll
Okay.
just resume in a minute. एक second.
Yes, sir.
Hello.
Yes, sir.
So okay. So I was saying, yeah, you have to mention that on the history as well.
Okay, sir.
Okay. Okay. Your next differential is cardiomyopathy.
Yes, sir.
Now, cardiomyopathy in such a young patient, you will have to explain what is causing the cardiomyopathy. And again, cardiomyopathy will be having symptoms of palpitations. It is not okay that it is possible that the initial symptoms could be shortness of breath, but then
Okay.
subsequently will have palpitations.
Okay.
Okay, so we go on to the examination. Any
Yes,
doubts
sir.
still up till now for the history?
So not from my side. I'll just take
Anyone
a
else can put
question.
it on that? Yeah. Okay, so you start with the examination.
So there's one question from the line, if it's all right to mention the history of cough for 6 months, or should we mention it as intermittent cough?
See, if the cough is there actually, which is significant enough to disturb her activities of daily living, you'll have to mention that for 6 months.
Okay.
Otherwise, you can say that you can describe it with the shortness of breath itself, that shortness of breath was associated with occasional coughing. But in this case, you had a history with, pink frothy sputum is also there.
Yes,
So
significant.
in such case, you can mention cough for 6 months. That is not a problem.
Okay. So I'll proceed.
Okay.
Examination.
Okay. Yes, I'm muting myself. Okay. Start.
Okay. Examination. The patient was conscious, cooperative, and well oriented to time, place, and person. She was sitting in bed, visibly in distress. After taking due consent, the patient was examined in a well-lit room, maintaining privacy. The patient is of average build and is well nourished. Height is 5 feet 2 inches, weight is 53 kgs, and BMI is 21.4 kg per meter square. Pulse rate was 124 beats per minute in the right radial artery with a regular rhythm. Underlying vessel wall is normal. There was no radial or radiofemoral delay. Volume of the pulse was low in right carotid artery with a normal character. Blood pressure was 100 by 62 millimeters of mercury in the right brachial artery in sitting position. The respiratory rate was 22 per minute and respiration was abdominothoracic. The temperature was 98.2 degree Fahrenheit measured orally, and the jugular venous pressure was 7 centimeters elevated above the sternal angle. General physical examination. Pallor was appreciated in the lower palpebral conjunctiva. There was bilateral pitting edema in the lower limbs, 0.5 centimeters deep till the level of the knee. There was no icterus, clubbing, cyanosis, or generalized lymphadenopathy. There were no cardiocutaneous markers or any stigmata of rheumatic fever or infective endocarditis. Cardiovascular examination, inspection. The size and shape of the chest is normal. There's no precordial bulging. Apical impulse could not be visualized. There were no visible pulsations. No scars, sinuses, or prominent veins were visible. A parasternal heave was present in the lower left sternal border. Palpation. Trachea was in midline. The apex beat was palpable in fifth intercostal space, 1 centimeter medial to the mid-clavicular line, and was tapping in character. Pulsations could be felt in the left second intercostal space. A diastolic thrill was palpated at the mitral area with patient in left lateral position with breath held in full expiration. A grade 2 left parasternal heave was palpable. Percussion was not done as it won't provide any extra information. Auscultation. First and second heart sounds were loud. A rough, low-pitched, mid-diastolic murmur of grade 4 by 4 was heard with the patient lying in left lateral position with breath held in full expiration. It was better heard with the bell of the stethoscope, best heard in the mitral area with no radiation. It was preceded by an opening snap. Abdominal examination. On inspection, the abdominal was scaphoid in shape. The umbilicus was central and inverted. All quadrants were moving equally with respiration. And there were no swelling, scars, sinuses, or fistulas or dilated veins. On palpation, there was no tenderness, guarding, or rigidity, and the abdomen was elastic in consistency. Fluid thrill was absent. Liver was enlarged 3 centimeters below the right costal margin in the mid-clavicular line. It was soft in consistency with rounded margins and smooth surface and non-pulsatile. The spleen was palpable 4 centimeters below the left costal margin in mid-clavicular line. It was soft in consistency and smooth surface. The splenic notch could not be appreciated. On percussion, the upper border of the liver span starts from the fifth intercostal space. Liver span was calculated to be 18 centimeters. Percussion of traverse space revealed a resonant note. Shifting dullness was absent. And on auscultations, vowel sounds were heard normally. So summary, on examination, there were second intercostal space pulsations, a tapping apex beat, a diastolic thrill, and a parasternal heaving was palpable. And there was on auscultation, there was grade 4 mid-diastolic murmur, loud S1 and P2 heart sounds were heard. And the pulse was low volume. There was tachycardia. The JVP was elevated, and there was bilateral pitting edema, anemia, and hepatosplenomegaly. So diagnosis, the patient is suffering from an acquired valvular heart disease, most likely to be mitral, most likely with mitral valve involvement and a stenotic lesion of unknown etiology, which is causing pulmonary hypertension. And the patient is in normal sinus rhythm with features of biventricular failure with no symptoms or signs of infective endocarditis or active rheumatic fever, and the patient has NYHA class 4 dyspnea. Yes, sir.
Okay, so come back to the first page. This is fine. Next page. Next slide. Okay, her blood pressure was 100/62.
Yes, sir.
What is the pulse pressure in this patient?
So 38.
Sorry.
100 minus
Hello.
62. Hello.
Yes.
Am I audible?
So what would be the pulse pressure? Yes, you're audible.
So 38.
38. So see, person who is having a low volume pulse,
Yes,
this
sir.
is 38 is almost normal pulse pressure.
Pulse
A person who is having a low volume pulse will be having a lower pulse pressure. So either I would still keep 100 as the BP, which is acceptable, but I think 62 शायद आपने ठीक से नहीं लिया है, थोड़ा सा ये गलत है. ठीक है, low volume pulse है patient को because आप mitral stenosis suspect कर रहे हो. So the pulse pressure is slightly elevated if you're keeping mitral stenosis.
Okay, sir. Yes, sir.
JVP is fine. I hope you have measured it correctly. Then next slide.
Sir.
This is fine. You need not mention 0.5 centimeters deep.
Okay.
Just say it's bilateral pitting edema. Then next slide. Okay, this is fine. Apical impulse could not be visualized. Okay.
Like
next.
Breast tissue.
हाँ ठीक है, it is understandable. कोई बात नहीं.
Yeah.
Okay, then trachea is in the midline. Okay. Okay, pulsations could be felt in the left. You should have written it as whether it is a palpable P2 or not. Pulsations could be felt in left second intercostal space means what? What pulsations are you trying to?
So, like the pulmonary artery hypertension only, like.
So, like for pulmonary artery hypertension, that has to be palpable P2.
Okay, sir.
Okay, I just saw a question from Sarthak. He's saying that diuretics will relieve the edema, tilts the diagnosis to CVS. I did also mention, see, in a patient who is having pedal edema and shortness of breath, if you are and you're giving diuretics, the edema is getting relieved after increased frequency of micturition. That will go more towards the favor of cardiovascular disease rather than a patient who is a known CLD. A known CLD who's having only pedal edema with the CLD is very unlikely he will have ascites as well. Now, in such a patient, when you give Lasix, he will have a reduction in his abdominal distension. He will not have, uh, if I would put it in other words, I would say that CLD patient to have breathlessness and having pedal edema and having a need to have a massive ascites. Now, if the person who is having massive ascites, giving Lasix will not relieve the ascites, will not have any effect on his shortness of breath, and may decrease the pedal edema to some extent. For him to be relieved of his shortness of breath, you will need to go for a therapeutic ascitic tap. If you consider this case of nephrotic syndrome patients will not have pedal edema along with shortness of breath. First of all, nephrotic syndrome patients will be having only pedal edema, and that will obviously be relieved by giving diuretics. So that is what I think you missed my complete statement. What I was trying to say at that time was that when a person who is having pedal edema and is having shortness of breath, you ask whether any medicine was given which relieved the symptoms, which that will point towards a cardiovascular pathology. If someone who is having pedal edema without any shortness of breath and you are suspecting whether it is likely due to a renal cause, obviously giving Lasix will relieve the pedal edema. But then the patient is not having shortness of breath. Similarly, if you're thinking about CLD will not have any shortness of breath. He will have abdominal distension. Okay, so I proceed. Okay, so apex was fine. The pulsations you should have mentioned P2. Diastolic thrill was palpated. That is fine. Okay, grade 2 मेरे को लगता है शायद grade 3 होगा. grade 2 इतना severe अगर उसको RVH है तो शायद grade 3 होगा. Okay, come to next slide. You need not mention this that it was not done at it as it won't provide any extra information. You just skip and come to auscultation. In cardiac cases, you need percussion only in very few cases.
So like
Auscultation, yeah, first and second heart sound were loud. The second heart sound का loud होना थोड़ा सा unusual है if the patient is having mitral stenosis. ठीक है. First, are you saying that both first and second were of same intensity?
yes, sir. Like, and like sir, tachycardia भी काफी था तो like काफी.
हाँ, ये हो सकता है. आप उसी tachycardia के अंदर वैसे ही S1 loud हो जाता है. और आपने बोला है कि टैपिंग था S1. So मतलब जो आपने palpate करा. I would not say that both were sound because S2 is slightly on a softer side in a case of mitral stenosis. Okay, then this is the description that should be whenever, even if you're presenting the case during your final exams. A rough, low pitch, describing the murmur completely, describing the grade, describing the position in which you have heard the murmur, describing the part of the stethoscope that you have used, bell or the diaphragm, okay, and describing the radiation. And it was preceding by opening snap. Were you able to appreciate a opening snap?
No, sir. It's a बहुत ज़्यादा tachycardia था. But then I read in the books like that, मतलब it's pathognomic of MS, like opening snap. Yes.
ठीक है, opening snap होता है, but see again the point is that when you're committing to the examiner that the pulse rate is 124, it is almost impractical, मतलब practically impossible, I would say, to appreciate an opening snap. Acha, anyhow, how do you?
So, like, what do we say that the opening snap could not be appreciable because
Yeah,
of
you
the
can
fast
easily say
heart?
that I could not appreciate the opening snap.
Okay,
Okay,
okay.
before we go, before we ask my question, I just want to ask, so trachea being in the middle, trachea being in the midline, have any specific significance here?
Well,
I would not say in a case of cardiovascular, I don't think so. It is having any specific significance. It is just the part of the system that you want to say. I don't think of any cause that can affect the trachea, a cardiac cause.
so, like, as
Okay.
in, what I read was
Yes.
that that if like the apex beat is shifted, although it's not shifted in this case, but if the apex
Yeah.
beat is shifted and if the trachea is also shifted with it, so like that becomes like a respiratory cause. But if the trachea is in midline and the apex beat is shifted, then we can attribute it to a cardiac cause. So that's I thought like I'll mention.
This is sort of a soft marker, I would say. It is not hard and fast that if see it could be possible that the apex beat is shifted because of the cardiomegaly.
Yes,
Okay.
sir.
And the trachea is in midline, but it is not, that does not absolutely rule out that the patient is not having a respiratory pathology.
Respiratory pathology. Okay,
Okay.
okay, sir. Yes, sir.
So this is something which is a very vague thing, which is I think wherever you have read it, that is fine. But you can, to an extent, I can agree to this statement that if trachea and apex both are shifted, then you can think of a respiratory. If trachea is in the midline and apex is shifted, you can think of a cardiac cause. That I take it, but I will not say it as a part. But to describe trachea in the midline, that is a part of the normal thoracic examination. You do it both in cardiac and respiratory.
Yes.
So, okay, so we go on to, so the question that I wanted to ask from all of you, how do you listen to the opening snap? Where do you listen and what is? I need your answers here in the question box. No, not at the apex. That is why I have asked this question.
At the base of the heart, like.
No. Third, near aortic, no. Third, left, no. So you always, yeah, you can say yes. Not just medial, but you can say it is in midline, in between the apex and where you listen for the murmur of TR, basically lower left sternal border. It is usually in between these 2 points, lower left sternal border and the apex, and you have to hear it while making the patient stand. You will not be able to appreciate opening snap when the patient is lying down. ठीक है?
Yes, sir.
So ये चीज तुम उसके बाद ही you will be able to appreciate opening snap. ठीक है, चलो next slide. Acha, before going on to, sorry, come back. Before going on to the next slide, this is what you have told about what you could hear in the apex. Cardiac examination is complete when you describe what you are hearing in the pulmonary area, what you are hearing in the lower left sternal border, and what you are hearing in the aortic area. So you should always mention that. I'm sure if you would have heard, you would have found a murmur of tricuspid regurgitation in the lower left sternal border. And if you're saying that you could palpate something in the left intercostal space, second left intercostal space, then I'm sure you would have appreciated a loud P2 as well.
Okay, sir.
Okay. So you have to mention all those things. Yeah, you have to mention all the areas. Okay, so in the abdominal examination, you're having a finding of hepatosplenomegaly. Now, this hepatosplenomegaly uh, is not related to RHD, I think, in any sense. I think that the patient needs further workup. The four cardiac areas, these are the areas that you should always auscultate: apex, pulmonary area, aortic area, and the lower left sternal border. So hepatosplenomegaly, plus you said that the patient is having pallor. So I think that needs to be evaluated in a different sense. Is not related to this case.
So what like
Okay, so this is how. Batao.
the heart failure, say congestive, like hepatomegaly. So
That will not
will
cause
it happen?
splenomegaly.
Okay, okay.
That will not cause splenomegaly. And more importantly, you mentioned that in your liver span was 18 centimeters. Congestive hepatitis के अंदर इतना ज़्यादा नहीं बढ़ता है liver का span.
Okay.
ठीक है?
Yes.
So this is something I think the patient needs to be evaluated for anemia with hepatosplenomegaly. That is a different approach in altogether
Yes.
system. We'll not go into that domain today. Okay, so now since you have made the diagnosis of valvular heart disease, mitral stenosis, at your level, at final year level, this is what is expected if you go about in a proper systematic way, telling your history and then giving the necessary examination in the correct way possible. Now, your final diagnosis, you should not say that it is of unknown etiology. You should say that it's a likely rheumatic, because even though there is no history, but because of the prevalence of rheumatic heart disease in India, it could be because of that only. Causing pulmonary hypertension, sinus rhythm, okay, that is fine. And IO, that is good, okay. And you should just write with currently in NYHA class 4. You don't need not mention dyspnea.
Okay, okay.
NYHA is for a cardiac case. It could be dyspnea, it could be fatigue, it could be chest pain, it could be palpitations. So you need not mention that it is dyspnea. Just write with currently in NYHA class 4.
Okay, sir.
Okay.
Yes. So now Piyush will be discussing the investigation. Yes, sir.
Okay, I see. Okay, chalo batao. Quickly go through it.
Just a second, sir.
Good evening, sir.
Yes.
Evening, continue.
Sir, I will be presenting the examination part. Sir, telecom routine examination
Okay,
करवाएंगे.
I would say, see, CBC is fine. Urine analysis, I really don't think it is needed. Electrolytes is fine. Lipid panel, again, in a young RSD, you will not find anything. Next slide. KFT is fine. Glucose is only for the surgical purposes. Cardiac enzymes, no role. No role in a patient of RSD. LFT is for hepatic congestion, that is good. Thyroid function is again more of related to surgery and these things that were mentioned, but you do not get it done in every patient who is a RSD. Okay. So imaging studies, yeah, you can go on to the next. So basically, if we talk about blood investigations, we are interested in CBC, we are interested in KFT and LFT. That is it, I think, not more than that. Okay, so imaging may you will go with a chest X-ray. Uh, I think I discussed with you guys chest X-rays last time. I think I taught you guys only, मेरे ख्याल से.
Yes, yes.
So I had already shown you X-ray of this case of typical mitral stenosis. Yes, you can skip this. You can share this PowerPoint with the rest of the class. They will. Yes, this is basically describing it in detail. Yes. Wait a second. What is this? What is the one on this side? This left heart border. What are you trying to say?
the double density of left atrium over the right atrium. So like it's not visible in the lower one, but if we see in the upper image, there are like I don't know if my
Yes,
pointer is
exactly. Yeah.
visible. So like
Yeah.
left and right
Yeah, yes,
atrium.
it's visible. So yeah, this is what I had taught you guys, that these are the two shadows, those which you were be pointing. I am not sure if I'll be able to use that.
I can give
Uh,
it to you, I think.
ठीक है, I
Yes,
hope
sir.
it is clear that this, yeah, yeah, okay. So next slide. Yes, so ECG is done. Fine. ECG, you check for the changes which has happened in the heart. You check for the sinus rhythm. If the patient is in atrial fibrillation, you check for whether what is the ventricular rate. ठीक है. Next, RVH. Okay. These things are not at all important for you guys. Only thing that you should know is that what is the normal valve area, which is 4 to 6 centimeters square, and what is severe. ठीक है. Biomarkers. Okay. Biomarkers are done in patients who have presented to us in heart failure. Like for example, this patient, as you were telling, was in respiratory distress, was having pedal edema. So in which we will be having a raised pro-BNP level. Okay, next.
So then management of heart failure. So I can go through it quickly.
Yeah, management of heart failure. Okay, just let me go through it. IV diuretics, first line, that is good. Lasix, thiazide can be used. Okay. Metabolic alcohol, that is the side effects. Okay, no problem. Loss of weight is used as a, yes. Okay, okay. And apart from the loss of weight, you also see the blood pressure. ऐसा भी नहीं है कि आप इतना diuretics दे दो कि patient shock में चला जाए.
Hypovolemia. Yes.
ठीक है. Yes. Okay, so yeah, ACE inhibitors have a mortality benefit definitely. So yes, you do give patients ACE inhibitors, but usually what happens in a case, this remodeling which is there, it is more of the case when the patient is having a cardiomyopathy or a ischemic disease. In a rheumatic heart disease, this remodeling of the ventricles is not taking place. You prefer giving diuretics and you prefer giving beta blockers to keep the rhythm in the normal. Okay. So this is this like ARNI and these things are more related to heart failure. Okay, beta blockers, yes. Okay, what is this?
So the like when do we prefer surgery and like when we
NYHA
use
class of symptoms 3 to 4. Signs of heart failure.
If the signs of heart failure are present and if the mitral valve area is less than 1.5 centimeters square, or if left ventricular
Less than
ejection
one, less than one, yes.
Okay, less than 1, so okay.
Okay.
And
Less
ejection
than 1.
fraction is less than 40%. And in case of pregnancy, we intervene and we do balloon mitral valvotomy. But in cases of MR or calcified leaflets or any thromboembolism, the valvotomy is contraindicated. So we do a mitral valve replacement and add warfarin prophylaxis for atrial fibrillation.
Yes. Okay. So this is good. Where have you been taught this?
So like courses, coaching.
Okay. So it's good. Okay. Okay. So more or less, this is what it is followed. Go back to that slide. Back to that algorithm.
Yes, I'm on that algorithm.
Okay. So yeah. So if I would say that yeah, that is what I'm saying. So if the signs of heart failure, okay, that is fine. Area is 1 centimeter, and NVHA, that is okay, fine. So, and you have given diuretics and all. BMV is fine. Associated MR, BMV is not needed, not done. Calcification, not done. Acha, one more thing that you need to know: if you are having a calcific mitral valve, you will not have opening snap.
Yes, sir, and no opening snap. Yes, sir.
Okay. So that is one clinical sign that people see to decide कि BMB करना है या MBR करना है.
Okay.
ठीक है, चलो. Presence of LA thrombus. In case of LA thrombus, nowadays we don't go for BMB, we will go for MBR only. ठीक
Okay.
है, आगे
Yes,
चलो.
contraindication for BMV.
Next slide. Yeah, next slide.
So like
Next
if
slide.
it's
Yeah, symptoms. So what? See, like this is what you have written is the management of heart failure. This is not related to a patient of rheumatic heart disease.
Yes, sir.
What apart from this algorithm that you have just shown, apart from that, everything is management of heart failure.
Yes,
Even the implantable cardiac defibrillator.
heart failure.
Like I said, I told you guys, ejection fraction in a case of pure mitral stenosis is maintained for a long time.
Okay,
Okay,
sir.
next slide.
So that is like for refractory heart failure only I've added. And
Yes,
if
yes.
like
Again, this is again heart failure, evabradin and resynchronization.
yes, sir. So
Next.
then preserve ejection fraction till we manage the comorbidities.
This is
and
not needed.
yes, sir.
It is not. It is nowhere related to the rheumatic heart disease.
Yeah.
In
So
all
then
patients,
salt
yes, salt restriction, good. Fluid restriction, good. Exercise जितना हो सकता है, that is fine. And omega-3, okay. ठीक है. So, okay, now any other doubts, any questions? What, see, this management wala aspect was slightly, it is, this much is not needed from you. And more
Yes,
importantly, it was more of a management of heart failure rather than the management of rheumatic heart disease.
yes.
Your vivas will not go into the management of rheumatic heart disease like valve area कितना होना चाहिए, कब करेंगे and all that. But हाँ, you should know the basics that we can go for a replacement when there is concomitant MR. We can go for a conservative procedure. There is calcification procedure, which is BMB, which will give us this time of the symptoms. But what is expected from you guys is the proper history, the description of the symptom, proper examination, mention the findings that you are able, things that you are unaware of. ठीक है, अब जैसे आपने ओपनिंग स्नैप लिखा था, वो चीज लिखने की जरूरत नहीं है. In a patient who is having a tachycardia of 130, you will not be able to find a opening snap. ठीक है?
Yes, sir. Yes, sir.
Okay, so any other questions? After that, we can then close this discussion. And what about your attendance?
Or I think if you log in from the HOD surgery, so the attendance
Hello? Hello?
Yes, sir. Yes, sir.
I'm sorry, I did not. Yeah, I think it is auto submitted. Na? Just send me, Rashmi, the copy of that.
Okay, sir. Okay.
The list that is there, you can send the copy.
Yes, sir. Okay, sir. I'll click the screenshot and send it. Okay, sir.
Yes.
Alright, sir.
Okay. So any other questions, or should we end?
So I think we can end. I can't see any questions in the chat box.
Okay. Okay. So I'll be exiting. Thank you.
Yes. Thank you, sir. Thank you so much.